cancer because it's one of my favorite topics, and I ideally would have 2 hours to really cover it, but I have a lot in the slides, and I think I can guide you to other things for persons that they are taking the exam, things that are likely to be on the exam. So I get a whole hour to talk about breast cancer.
Just click one time into the slides, then you can advance. Sorry.
Oh, there.
Nice.
Okay. So I've got hints for study and test taking, particularly if you're going to take the BCOP exam. What I think is most helpful is review what you think you know best to confirm that, because then you can get some questions out of the way that you're sure you'll get right. Like if you're really familiar with GI cancers, you can start with that. You can start with that and confirm that, and then go back to things you're unfamiliar with. I save statistics for the last because I was hoping I could do the best on that by saving it in my head for the last. Review the self-assessment questions that are provided in the 2015 material. Some questions will be exactly the same, or they will use the same rationale. You could say, oh, I know where they got that question, just use different names and maybe slightly different drugs. The questions, I think the most important thing about taking the test is the questions are multifaceted. The material is presented to you in one layer, but the questions come at you and they generally have like 4 layers in there, and you're provided with material that's like screening and prognostics and diagnosis or staging in pieces, and then treatment in pieces. But the tests it's all in one question, and that's what makes it difficult. So you got to look at each piece in one question. And they're all multiple choice. I think most people that study 2 are pretty easy to eliminate. 2 will be very close, but one of them is the best answer, the slightly better choice. Really new information that you might be familiar with will not be on the test. Answer as many questions as you can. If you get stuck, move on. Breast cancer is really a complex disease. We have to take into thought, we have to think about age and menopausal status. Genetics do play some role in this disease. We have to think about the histologic subtype of the tumor, the nuclear grade of the tumor or the proliferative capacity of the tumor, the stage of the disease, the hormone, ER/PR status of the tumor, and also whether there is a human epidermal growth factor type 2 receptor or HER2 receptor expression. So this is the content that I'm going to go through in an hour. I'm going to go through screening, prognostic tools, etiology, risk factors, risk reduction, the types of breast cancer, management of the lower stages of diseases or risk factors for breast cancer. That's lobular carcinoma in situ and ductal carcinoma in situ. Management of early stage disease. I have several slides on endocrine therapy because it's important in this disease. Neoadjuvant therapy, adjuvant therapy, management of locally advanced disease, and management of metastatic and recurrent disease. And I have a couple of slides about specific drugs as well. So I've got, I think, 60-some slides. I can go through these quickly, I promise. I think most of you probably know that breast cancer is the most commonly diagnosed cancer in women in the United States, but it is not the leading cause of death. I find it interesting that it's 2 hormone cancers. That men, it's prostate, most commonly diagnosed. Women, it's breast cancer, most commonly diagnosed. But the most common cause of death in men and women in the United States due to cancer is lung. So that's just, I find interesting that those statistics. So screening, I'm going to start. The first screening is breast self-exam, and that was widely done years ago, but it's generally no longer recommended. Clinical breast exam is a breast exam performed by a healthcare provider, also not uniformly recommended. However, the American Cancer Society recommends that this is done every 3 years by a qualified provider for women between the ages of 20 and 39, and annually if you're greater than or equal to 40. My next slide is on mammography, which falls into screening, and then I have a slide on breast MRI, which is new information on this test, but that is used as an adjunct to mammogram in certain patients. So mammography. We know that the annual mammogram reduces mortality in women in my age group, greater than or equal to 50. Data is limited in Mary's too, just barely. She giggles at me. Data is limited in women greater than 75, not there yet, greater than or equal to 75, and neither one of us. And it's not indicated in women with serious coexisting illness or life expectancy less than 5 to 10 years. Where it's controversial is the age group between 40 and 59. There are still trials that are trying to assess the benefit, but they're not consistent. It's under debate, and risk versus benefit needs to be considered. I certainly had them annually after 40 because that was the push at the time. So breast MRI. The American Cancer the American Cancer Society guideline says that this is an appropriate test in addition to mammography for women that are genetic carriers that carry the mutation to the breast cancer gene BCRA1 or 2, or if you have a first degree, or if you are a first degree relative of a BRCA mutation carrier but you are untested, or if your lifetime risk is estimated at 20 to 25% or greater for developing invasive breast cancer. That's the American Cancer Society's current guideline. There are other recommendations for doing a breast MRI, and those are for women that received chest radiation between the age of 10 to 30 years, and that's most likely women that were treated for Hodgkin lymphoma that were in that age group. They should maybe have a breast MRI to detect earlier lesions. That's a very aggressive breast cancer when that does develop in those women. And then there are some inherited syndromes which are highly associated with cancer. And if you have that syndrome or the gene for those syndromes or first degree relatives with those syndromes, breast MRI may be appropriate. It is controversial if other high-risk patients that have breast MRI, we're still accumulating data. And then if you have a personal history of breast cancer, is breast MRI a better test? We don't know. And most payers are not paying for them. So we've gone through screening real quickly. Now we're moving on to the prognostic tools that are available. Adjuvant is one tool, and then there is the gene expression assays. The ones that I'll talk about are Oncotype DX, Mammoprint, and PAM50, which is new on this exam, the PAM50. Adjuvant is available in an online test. It's a decision tool for adjuvant systemic therapy. And it estimates the 10-year risk of cancer-related mortality or relapse without adjuvant therapy. It estimates risk reduction and risk from therapy. The limitations are that not all prognostic factors are included. HER2 status was not included, and small tumors are not well characterized when you're looking at this. It has good graphics, however, for patients, and it's continually updated with new clinical trial information. So again, that's a decision tool for whether patients should receive adjuvant systemic therapy, because they don't all get it. Oncotype DX is a diagnostic assay. Remember, we're in the gene assays now. It quantifies likelihood of breast cancer recurrence in newly diagnosed early stage breast cancer. So you need to know, if they ask you what tool would be helpful for this woman, if she presents with metastatic breast, this is not helpful. Or locally advanced, this is not a helpful tool. So that's where the questions get multifaceted. They'll say, what should we offer to this woman? And if in there they've got like 5 things, but you see Oncotype DX is in there and it's a metastatic patient, it's probably not appropriate. It's not, or that's the wrong answer. So this test screens for the expression of 21 genes, and it results in a recurrence score. It can be used to determine the risk of recurrence or deaths from breast cancer in hormone receptor positive, HER2 normal. And I just want to mention on HER2, it's reported often or in old data as positive or negative, and we hardly ever use that term anymore, although some of the assays do report as positive or negative. We use the term HER2 normal for negative, or HER2 amplified or overexpressed for positive. That's more appropriate terminology. HER2 normal or HER2 overexpressed is negative positive. And we like to be current. And that is the risk in node negative, and that's important too, node negative disease and invasive breast cancer, which is the most common type of breast cancer. If that score is calculated to be a low score or less of 18, you have a low risk for recurrence if you treat just with tamoxifen. And you don't need adjuvant chemo. So you see how they can get multiple questions out of this one test. They can talk about an early stage patient, and they could say she's node positive, and that would throw this off. So you kind of got to know what these tools, they really test the depth of your knowledge with the differentiating between those last 2 best answers. So if you get a HIDE score greater or equal to 31, there's a high risk for recurrence even with endocrine therapy. So patients should receive adjuvant chemo followed by endocrine therapy. If you are scored with an intermediate score, there are some trials underway. Taylor RX is a trial that's underway to determine the value of additional therapy, and they're looking at hormonal therapy versus chemotherapy followed by hormonal therapy, or endocrine manipulation followed by chemotherapy. So it's controversial what to do with patients with lymph node positive disease. So the RX Ponder is underway. That's another trial in this patient, because we want to know really, there's controversy about the benefit of anthracycline-based chemotherapy in these patients. And then if you get a recurrence score of 25 or less in this trial, you're randomized to endocrine therapy alone versus chemotherapy followed by endocrine. So there's two trials looking deeper at Oncotype DX, and that's the Taylor RX and the Ponder RX. Next is Mammoprint 1, and that screens for the expression of 70 genes. It results in a good or poor prognosis classification. It might be useful in determining risk of recurrence when deciding on adjuvant therapy. And it used to be that you had to have fresh frozen tissue, and so it limited the utility of this test if you didn't have the right handling for the tumor. But now we can use paraffin-embedded tissue, which is most often the way the tissue is handled, and that became available in 2012. So I think this will have broader application in the future. PAM50 screens for 50 genes and predicts a distant relapse-free survival and likelihood of recurrent at 10 years, and I think that's pretty interesting in ER-positive postmenopausal patients only. So if you got a premenopausal patient, so just make your little table up. This is not worthwhile for them. And node-negative or node-positive patients that receive endocrine therapy. So kind of do your tests and line them up. I think there might be a table that has that in the review materials. So the review materials, there's available online here. The chapters are there unless you purchase them. Then also what was presented at the meeting for the updates are slides. And I think the slides are really useful because they are more questions. And there's a couple in there I'm going to point out that you should look at that I think would be really good test questions in the slide material. So what causes breast cancer? Largely, we don't know. The cause is unknown. We think genetics plays a role, or we know genetics plays some role. We know that we see tumor suppressor gene mutations or abnormalities in patients with breast cancers. BRCA1 and BRCA2 and P53 are tumor suppressor genes. Patients with mutated BRCA1 and BRCA2 are at risk for development of breast and ovarian cancer. The prognostic significance of carrier status is disputed. There's mixed results from the clinical trials. So we know it's correlated. They give you some numbers and percentages, but the different trials that looked at large groups of patients, the results are conflicting. P53, I think, has the nice name of the guardian of the genome. That's a tumor suppression gene. But about a third of breast cancer patients have mutation, inactivation, lost, or downregulated expression of this guardian of the genome. Then we have more genetics. We have progression genes, and the one that we definitely do know about is the human epidermal growth factor receptor 2, or HER2. That's a proto-oncogene. An amplification or overexpression occurs in, again, about a third of breast cancer patients, and it imparts a poorer prognosis. We once thought, oh my goodness, you're HER2 amplified. This is a good thing because we can use trastuzumab, but generally this is a more aggressive tumor. So that, when you look at prognosis, HER2 normal is a slightly better prognosis than HER2 amplified. So many test questions in the past have focused on which test to use for HER2, and the optimal test really is not known. I guarantee they're not going to ask you about FISH or in situ or hybridization. They're just not going to ask that because we don't know the answer. Most often FISH is used, but I just don't think that would be, they'll give you the results, but they won't say which is a better test. So breast cancer risk factors. Greater than 60% of patients really have no identifiable risk factors beyond being female and being older, increasing age. As we get older, the incidence increases as females age. We also know that the risk factors, if you have a family history of breast cancer, and the closer they are related to you, the higher your risk. We know that endogenous estrogen exposure increases the risk across the board. Females that that have their first date of menstruation when they're less than equal to 12 years old are more likely to have a higher risk. If you have late natural menopause greater or equal to 55 years old, or the age at the birth of your first child is greater than or equal to 30, or you never had children, you have higher endogenous estrogen exposure, which correlates to higher risk. Other risk factors are the presence of benign breast disease, radiation exposure, whether it's from the atomic bomb or whether it's from treatment for lymphoma, we know increases your risk, or other cancer we know increases your risk. The correlation between obesity and your BMI, body mass index, it's a complex relationship between risk here, but there are some things that we do see that if you are larger, there's a slight decrease. If you are obese, there's a slight decrease in risk if you're premenopausal, but it flips when you're postmenopausal. So what do you do with that data? Be heavy before you stop menstruating and then get thin. I don't know that. I don't think we know what to do with that data yet. There is certainly a lower risk associated with women that exercise, that have increased physical activity. Higher dietary fat is positively correlated with increased risk. And then the use of exogenous estrogen is positively correlated with increased risk. I have a slide on the Women's Health Initiative because I think it was an important, large trial and something important to know. As you can see, if you've done any studying for breast cancer, there are a lot of abbreviations and there are tons of trials. Lots of trials in breast because it's a big disease. Alcohol is positively correlated with risk. The greater alcohol consumption, higher risk of breast cancer. And then breast density is correlated to risk, and breast density we have a lot more data, and that's reporting mammographic patterns, looking at patterns of mammography. Breasts that are more dense, higher radio density versus lower or radiolucent. So higher radiodense breasts, there is a higher correlation or a higher risk for developing invasive breast cancer. So those are the risk factors. And just quickly to go through the Women's Health Initiative, this was a trial that looked at many women, Canada and the United States. And a lot of them were nurses, a lot were healthcare providers. But women received estrogen and estrogen plus progesterone, the brand name Premarin versus Prempro. The Premarin arm was stopped early after 7 years because there was an increased incidence of stroke, and the Prempro arm was stopped early because there was an increase in breast cancer cases. So when they looked back at what data we did have in the Women's Health Initiative, there was little benefit related, because the trial was undertaken because we wanted to look at, would estrogen help protect your bones and protect your heart, bone and heart disease, but we found different things. We found that there was little benefit related to cardiac events and questionable bone benefit, and some data suggested estrogen alone may impart a lower risk of breast cancer. That doesn't make sense, but we really need more studies because we think more estrogen increases your risk. But that was what was determined with a trial that was stopped early, but we have a lot of women were looked at in this trial, a lot of very similar women. So what can we do for risk reduction? So we've talked about screening, we've talked about prognostic factors. Now we're going to get risk reduction is something that has been widely studied in breast cancer, and there's some good information, there's a lot of conflicting information. So we know that prophylactic mastectomies decreases risk of developing invasive breast cancer by at least 90% for women with high risk of developing invasive breast cancer. Bilateral oophorectomy decreases estrogen exposure and decreases your risk by at least 50%. And when you have a person such as Angelina Jolie who makes this decision to perform both of these surgeries, it gets more of that knowledge out there. I probably, if I were her, would have made the same decision, having lost her mother as a young woman of ovarian cancer, and she is a carrier. So what do we do for prevention or risk reduction? Continuing on, the breast cancer prevention trial compared tamoxifen versus placebo, and they broke out the women as whether you were greater than 60, presumably postmenopausal, and whether you were 39 to 59, presumably pre or perimenopausal. And they looked really at lobular carcinoma in situ, which is not even a premalignant lesion is really a risk factor for breast cancer. And, both breasts, when you have this lesion, both breasts are at risk for developing in a disease, even if they only found a lesion in one breast, for developing invasive breast carcinoma. The benefit, though, was seeing that patients that received tamoxifen, there was a reduction in breast cancer patients in women that had LCIS, lobular carcinoma in situ. The risk and the risk for any long-term therapy with tamoxifen is endometrial cancer. Other risks are clotting, thromboembolic events, and they were mainly seen in women that were over 50. Another complication or risk that was seen when patients received long-term tamoxifen is cataracts. So those are three things you see, if that's a question on there, that it's endometrial cancer or the risk of tamoxifen therapy, thromboembolic events, and cataracts. There's really no reliable data regarding survival because crossover was allowed. They looked at the subset patients. They looked at the breast cancer 1 mutation. There were patients that were carriers, and there was no reduction in risk. However, if you had the mutation of BRCA2, there was the same reduction in risk. And I think that's an interesting subset analysis. Kind of detailed. I don't think that's at the level that they would ask that question. The STAR trial, and I think this one was very interesting because there was FDA approval after this, and now when we've looked at this trial after 10 years, we see something different. The STAR trial was tamoxifen versus raloxifene. Most of these trials were conducted here. STAR was definitely conducted here, and I remember dispensing these drugs or handling them. Women received tamoxifen or raloxifene for 5 years. They were all postmenopausal women. The benefit seen was that there was a reduction in invasive breast cancer in both arms. There was no, we were looking at bones, particularly for raloxifene, and there was no difference in fractures in the 2 arms or total deaths. The risk again was endometrial hyperplasia in the tamoxifen arm. This trial actually led to the FDA approval for raloxifene and for the reduction in risk of breast cancer in postmenopausal women with osteoporosis and in postmenopausal women at risk. And this is still offered to women and still part of the recommendations, although now we've looked at it recently, the trial data, again, where we've looked at patients that are still alive or have died since the trial, and now we see a significant risk in invasive breast cancer in the raloxifene arm compared to tamoxifen arm. So Mary always laughs at me, but I do have I think I have several slides devoted to tamoxifen because I'm a huge fanatic of tamoxifen, because it is a good drug. And definitely, when we look back again in this 81-month look back, the toxicity was still greater in the tamoxifen arm. Very interesting that you get an FDA approval and you think one thing and you look at it years later and it's different. So the SERMs, the selective estrogen receptor modulators, teremethine, we always mention teremethine because it was because it was looked at, and it was something that's used a lot in Europe, so sometimes it's on the test. But no data is really available that it's beneficial for chemo prevention. None of the trials showed that it was better, and there's really no advantage over tamoxifen for the treatment of breast cancer, endocrine management of breast cancer. Some trials looked at the aromatase inhibitors, the ATAC trial, MA17, IES, Big 198, and they all revealed that there was a reduction in contralateral breast cancer. So those were given to women that had breast cancer and that involved one breast, and all of those patients they were postmenopausal women, they received aromatase inhibitors, anastrozole, exemestane, or letrozole, depending on the trial, and they all had a decrease, they had reduction in breast cancer occurrence in the other breast. The MAP3 trial was this is more trials, but the MAP3 trial was a postmenopausal group with one risk factor for 5 years. They were either going to get exemestane or placebo, or they got exemestane plus celecoxib. That arm was halted early due to cardiovascular risk. But what we did see is that there was significant reduction in the incidence of invasive breast cancer patient in exemestane treated patients. So the limitations was that we still have short follow-up on this trial and small number of patients. The IBIS-2 trial compared anastrozole or placebo. The median follow-up was 5 years. The benefits were that there was significant reduction in both invasive and non-invasive breast cancers favoring anastrozole. However, it is not FDA approved for this use. But NCCN recommends, and breast is kind of heavy on the NCCN recommendations. Sarah is not always in favor of the NCCN recommendations because everything is in there. But they still have this listed as a category recommendation for postmenopausal women desiring risk reduction therapy. Now, if this were a question, they would say it's an NCCN recommendation. They wouldn't say that it's universally accepted. Types of breast cancer. We've already discussed lobular carcinoma in situ, which is really not breast cancer. It's not even a premalignant lesion. It is a risk factor for breast cancer. Ductal carcinoma in situ has been called a premalignant lesion, depending on what you're looking at the material, but it is treated and it is categorized under the types of breast cancer, but it really is not a cancer. It's kind of a premalignant lesion, but it can progress or recur and come back differently. The most common type of breast cancer is invasive ductal carcinoma. Greater than really 80% of patients have this diagnosis, and it does have the worst prognosis. So most of my therapy will be related to treatment for invasive ductal carcinoma, and it's broken down into early stage disease, locally advanced disease, and metastatic or recurrent disease. So once you get a handle on that stuff for breast cancer, I think it makes it all much easier to look at. This is all invasive ductal carcinoma, and it's the 3 different stages. Inflammatory breast cancer gets a slide on its own because it is a unique entity, and then there are also some very rare subtypes which I won't go through. There's some sarcomas and there's some pageants. There are some weird breast cancers that they're so rare that they wouldn't be really on an exam. So what do we do with lobular carcinoma in situ? It's controversial. Do you do surgical resection? Why we're seeing this, and we're seeing more of it, is mammography. We got this lesion. What is it? We're gonna take it out, and then we find out that it really isn't what we thought it was. It's not even cancer. So it is often surgically resected, and whether this helps rule out DCIS or not, we don't know. It's controversial. Following surgery, you can observe them, or you can talk about risk reduction, and that's where some of those trials came in. You can use tamoxifen for premenopausal, and that is always the answer. That if they're doing endocrine therapy in a woman who is premenopausal, the answer is always tamoxifen. It is never an aromatase inhibitor. So that'll get you one question for sure, because they will always ask a question to trip you up there. And you could use tamoxifen, anastrozole, exemestane, and some recommend raloxifene, but I think that new data is going to change it in postmenopausal women for risk reduction if they have a resected LCIS. And in some patients, they may even recommend, if they have other risk factors, multiple other risk factors, bilateral mastectomy. So I think we're seeing more of this because we're looking at women closer and earlier, and we're looking at women that are at risk, and we're looking at risk factors and cumulative risk factors. So let's move on to ductal carcinoma in situ. So there are 3 approaches to treat ductal carcinoma in situ. You can do a lumpectomy. The other term for lumpectomy is breast-conserving surgery. It's used interchangeably in the trials, and followed by radiation. You could do a total mastectomy with or without reconstruction, or you could do a lumpectomy without radiation. So there is no survival difference between the 3 approaches, but if you gave radiation, it reduced the risk of recurrence by 50% in patients that have breast-conserving surgery. Axillary node dissection, AND, is not recommended for this stage of cancer or this pre-malignant lesion. Sentinel node biopsy should be formed at the time you do surgery if you think there's a chance you won't be able to biopsy that node in the future because of your surgical approach. And the NSABP B24 trial revealed that tamoxifen for 5 years for ER positive, hormone receptor positive ductal carcinoma in situ following lumpectomy is the way to treat patients because it prevents advancement to invasive. And we're getting longer-term data about whether we should use a different agent or whether we should continue for 10 years. And again, tamoxifen is a good drug. And if you're still premenopausal, and you haven't recurred, it might be a good drug to stay on. But definitely 5 years of tamoxifen is the recommendation if you had a lumpectomy for ductal carcinoma in situ. So now we're going on to what's also called early stage disease. And that's stage 1A, 1B, 2A, or 2B. The goal of treatment for this is cure. Breast conserving surgery or lumpectomy at this stage of disease is always followed by radiation. There's a lot of dense material on the slide. Reread the slide because it'll help you figure out what is the best answer if they give you some options. They like to ask, who gets radiation? And there are some patients that have to have radiation, and there are some that don't. So radiation, if you did a complete mastectomy and you had close margins, even if it's lymph node negative and a small tumor, you still should get radiation. Or if you had many positive lymph nodes, you get radiation, even if you had a mastectomy. You should consider radiation in patients that had a mastectomy, not breast conserving surgery, if they have 1 to 3 positive nodes, they have negative lymph nodes, but they had a larger tumor and positive margins. If you have a lymph node negative, if you are lymph node negative, but your tumor is small, but you had close margins. So I think the next one is a good case for who really radiation is not recommended if you have a complete mastectomy and have no positive nodes. You have a small tumor and you have negative margins. You had a mastectomy. You didn't have a lumpectomy. So reread the slide if you're going to take the test. There's some things they can pull out, again, the multifaceted questions out of these types of slides. And in this early stage disease, some patients need neoadjuvant chemotherapy, which is chemotherapy prior to surgery. So to distinguish neoadjuvant from adjuvant, neoadjuvant chemotherapy or systemic therapy is therapy that precedes the surgery. So you get that first, then you get your surgery, and it's often followed by adjuvant or chemotherapy after your surgery. So I want to have several slides here on endocrine therapy because it's so important in this disease state. So if you are premenopausal, the recommendation for early stage disease is tamoxifen times 5 years. Ovarian ablation or suppression may be considered, if not amenorrheic, following chemotherapy. After 5 years, if you're still premenopausal, you could do no further therapy is kind of the current recommendation, but there are conflicting trial data with continuing for 10 years. I think if it were me and I was offered it, I would continue it if I were premenopausal. If you become postmenopausal after 5 years, you should consider an aromatase inhibitor for another 5 years. So how about the use of aromatase inhibitors in premenopausal women? The SOFT and the TEXT trials address that question. They used ovarian suppression and tamoxifen, or ovarian suppression or exemestane times 5 years. So they all got ovarian suppression, and one group got tamoxifen and one got exemestane. There was a 5-year median follow-up, and the 5-year disease-free survival rate was slightly higher in the aromatase inhibitor arm, but this is not currently is not a current recommendation by ASCO or NCCN because they still don't think that the trials are confirmed. They want conformatory. So really, if the woman is premenopausal, aromatase inhibitors are not the way to go. It's still tamoxifen. So even though we saw this slightly, the 5-year disease-free survival was slightly higher in the aromatase in the exemestane arm, the groups that oversee and provide guidance still want confirmatory trials. So again, I talked about early stage disease premenopausal treatment. Now this is endocrine manipulation or hormone therapy of postmenopausal with early stage disease. The recommendation is accumulating that it's an aromatase inhibitor first for 5 years. The other things that can be offered is tamoxifen times 2 to 3 years, followed by an aromatase inhibitor to complete 5 total years or up to 5 years of the aromatase inhibitor. So it could be 2 to 3 years and then up to 5 years or 7 years of endocrine therapy. Another option is up to about 5 years of tamoxifen, followed, because we have patients that got that and then we switched them to an aromatase inhibitor and we have results for them. Followed by an aromatase inhibitor for 5 years, or consider tamoxifen to complete 10 years if you have a recurrence in that 10-year period. Or you can use the aromatase inhibitor for 2 to 5 years, followed by TAM to complete 5 years. So all of those are recommendations. I think that the first one is probably becoming more favored now, and I don't think they would say this or this. They would have probably that first one as an option versus something else that's not endocrine therapy. Like maybe they'd have a Lupron on there or something, or Zolgensma, which you don't give to postmenopausal women. So early stage disease endocrine therapy combination. So these were, before I was talking about single agents, I was talking about tamoxifen or exemestane. But there were a lot of trials that looked at combinations of endocrine therapy. So they looked at for premenopausal women, they looked at LHRH agonists and tamoxifen, and it was not significantly better than either modality alone. So they're not often combined. For postmenopausal women, the ATAC trial, again another trial, the which was anastrozole plus tamoxifen, we had that trial here, was no better than tamoxifen alone, and the ATAC trial revealed some other results, which I'll show you later. So the combination then they looked at was chemotherapy alone better than tamoxifen alone, or combination. But for pre or postmenopausal women, chemotherapy followed by tamoxifen appears to be better than chemo alone in the hormone positive patients. Oh, there's my slide. Tamoxifen is a good drug. So the metabolites of tamoxifen, my favorite slide, appear, and I haven't had to change it in 4 years. I know. The metabolites appear more active than the parent compound. Now, let's talk about CYP2D6 testing. There's a hypothesis that polymorphisms in this enzyme can lead to increased or decreased active metabolites with improved or diminished outcomes. The retrospective data is contradictory. Routine CYP2D6 testing is not routinely recommended. So if that's a question, it's not routinely recommended. And it would be a lumped question, so I think I can get rid of answer A. So drug interactions. You do not want to combine tamoxifen with strong or moderate inhibitors of CYP2D6. So if the question is, I've got to use an antidepressant, venlafaxine is the answer for 2 reasons. It's helpful it doesn't interact with tamoxifen, and it also is proven to be beneficial for hot flashes that are induced by treatment for breast cancer. If other selections are fluoxetine, paroxetine, and boy, we used a lot of paroxetine in women because we just thought it was a milder agent and for depression until we figured something out about this. And as well as bupropion are not good choices because of the drug interaction with tamoxifen. So should we give more than 5 years of tamoxifen? This is some of the trials that we're looking at now. The ATLAS trial, with 10 years of tamoxifen, there was an improved risk or less risk of recurrence and better mortality data versus 5 years of tamoxifen. But longer tamoxifen, there was also increased toxicity, pulmonary embolus and endometrial cancer specifically. The ATOM trial was 10 years, and there was improved risk of recurrence, meaning you wouldn't recur. The language seems flipped. But there was not any improvement in breast cancer, mortality from breast cancer. NSABP-B14 conducted here as well was conflicting with these other 2 trials and showed no benefit beyond 5 years. The ASCO guidelines recommend women who remain premenopausal or perimenopausal should be offered an additional 5 years of tamoxifen. So now more trials on the aromatase inhibitors. I briefly mentioned them, but I'll go through them quickly again. The ATAC trial, which was an anastrozole plus tamoxifen, or the 2 separately, revealed that anastrozole was superior in postmenopausal women to tamoxifen for early stage disease. Not a confirmatory trial, so I'm not sure that would be a test question. Letrozole, the big 198, was shown to be superior in this trial for early stage disease. I believe that there's been a lot of discussion that that was a relatively flawed trial, and that's why letrozole is really not caught on for postmenopausal women. There's a recent trial still being looked at, anastrozole versus, which was a comparative compared two different aromatase inhibitors times 5 years, and it favored. It was interesting because it favored exemestane, which is a steroidal aromatase inhibitor, versus anastrozole. Anastrozole is a different type of aromatase inhibitor, and it favored as the initial AI in postmenopausal women, but it's not FDA approved for that indication. So if they ask you that question, you probably won't get it paid for by a payer. So then what about switching? If you're on tamoxifen for 2 to 3 years and then you switch in a postmenopausal woman to an aromatase inhibitors, all of the trials favored switching after 2 to 3 years to an aromatase inhibitors in postmenopausal women compared to 5 years of tamoxifen. So you got to kind of read through that endocrine stuff because the trials are kind of detailed. A little more trials, quickly. MA17 was tamoxifen times 5 years, followed by letrozole placebo times 5 years, and that trial didn't reveal much about tamoxifen, but revealed that letrozole was superior to placebo. Oh, that's good. But BSABP B33, tamoxifen times 5 years, followed by exemestane times 5 years, was stopped early because of the data that came out with the MA17 trial, and people just dropped out of the trial, so we had small follow-up. We didn't get our full number of patients accrued, and we didn't get the follow-up that they wanted for that trial to make clinical distinction. NCCN guidelines, they indicate that all 3 of the aromatase inhibitors have similar anti-tumor efficacy and similar toxicity. The optimal duration of aromatase inhibitor therapy is uncertain, but I do have a take-home slide later about aromatase inhibitors in postmenopausal women. The ASCO guidelines for adjuvant endocrine therapy is only for patients that express hormone receptors, ER/PR. If you are pre or perimenopausal at the time of diagnosis, the answer is tamoxifen. Most postmenopausal women should consider an aromatase inhibitor to lower recurrence risk, or tamoxifen for 10 years. The optimal timing and duration of endocrine therapy is still unsolved. So later I talk to you about data for continue in later stage disease about aromatase inhibitors, and I'll point out that key point from that slide. The goal of treatment for that early stage disease, that's 1A, 1B, 2A, 2B, goal is the cure, chemotherapy is the gold standard, and trastuzumab-containing regimens are required in patients that are HER2 amplified. So adjuvant chemotherapy, and sometimes we give, if it's a large tumor, we are now seeing a lot more neoadjuvant chemotherapy given so that they can do breast-conserving surgery, and then they complete that therapy post-surgery, what the course that would have always been adjuvant therapy. So sometimes you give adjuvant therapy a little bit before, do the surgery, and complete it after. Anthracyclines and taxanes are the standard of care for patients who receive adjuvant chemotherapy. Dose-dense AC, doxorubicin, cyclophosphamide, followed by weekly paclitaxel plus trastuzumab for HER2 amplified patients is preferred, but may be too toxic for some patients. I don't know if Mary's stretching or she's saying hooray for that slide.
I'm saying hooray for that
slide.
87-year-old women
Let's
not
give her the dose stats
when their creatinine is 2.8.
Then that's Mary bringing a very important clinical case that would be a good one to discuss at the end. And then you can use, so if you've got some choices on there, and in your choices are CMF, which is cyclophosphamide, methotrexate, fluorouracil, or TC, which is taxotere, docetaxel plus cyclophosphamide, you only use that for node-negative disease. Lower intermediate risk node-negative disease. You need an anthracycline for women with node-positive disease. So read each little niblet of information they give you about that patient. Trastuzumab we can use for HER2 amplified tumors that are greater than 1 centimeter. NCCN, the conclusive says really there's not conclusive data about the smaller tumors. Trastuzumab is generally given concurrent with the taxane portion of the regimen or sequentially after the end of all chemotherapy. It should not be given concurrently with an anthracycline. There is one exception, but they don't get a lot of doses, and that's neoadjuvant chemotherapy where they are giving trastuzumab plus paclitaxel. You generally don't give it concurrent with an anthracycline, and that could be a test question. And it would be bundled into other cardiotoxic issues with breast cancer treatment, that type of question. Trastuzumab is given for 1 year, except one regimen where they give docetaxel plus trastuzumab followed by FEC chemotherapy, fluorouracil, apirubicin, and cyclophosphamide. Trastuzumab is given for 9 weeks. Trials with trastuzumab where they looked at longer treatment with trastuzumab. The HERA trial revealed that 2 years of trastuzumab added no benefit. So if the question is, should we give 2 years? Probably isn't beneficial. It's 1 year. The recent FAIR trial revealed that they compared 6 months and 1 year, and it was not inferior, but it hasn't caught on that maybe we should just treat for 6 months because it really needs a confirmatory trial. So it is 1 year. Don't give less than 1 year in HER2 amplified patients, and 2 years is too long. More than 1 year is not beneficial. Cardiac monitoring should be performed in patients that receive trastuzumab, and trastuzumab can be given weekly or every 3 weeks. I've got a couple slides intermixed in here on taxanes because we use them a lot in this disease. Paclitaxel and docetaxel have been compared quite a lot in this disease. There is no difference between the two. However, when you looked at paclitaxel, we do know, and this is a kind of important development that we found probably 4 years ago, that there was improved disease-free survival and overall survival when we administered paclitaxel weekly versus every 3 weeks. So our builders probably even know that because most of our regimens are weekly. We've got a few where we give the 3 weeks, and some of the clinical trials have 3 weeks. However, there's a higher incidence of, just to distinguish between the two, the weekly and the 3 weeks, there's a higher incidence of febrile neutropenia with the 3-week dose and a higher incidence of grade 3 and 4 neuropathy with the weekly paclitaxel. And I think that's, Mary saved that little 87-year-old lady from really bad neuropathy, I think. Dose-dense therapy. Dose-dense therapy where we give big doses closer together, where we give in breast cancer, every 2 week AC followed by paclitaxel revealed, dose-dense paclitaxel revealed prolonged disease-free survival and overall survival compared to every 3-week therapy. However, not everybody is a candidate to get those doses crunched together like that. And if you're giving dose-dense therapy, they have to have growth factor support to maintain the dose-dense interval. Many studies without taxanes indicate that there really is no benefit for a dose-dense approach when you're only giving anthracyclines. That's kind of a tricky distinction. And remember that weekly paclitaxel revealed the optimal outcome, not 3 weeks. So now we're moving on to the next stage of breast cancer. This one is referred to as locally advanced, is probably the most common term, and that's stage 3A, 3B, 3C. And we always say non-inflammatory because that's a weird entity in itself. So if the disease is operable, you can do primary surgery and do a mastectomy in this state of disease. If you prefer a lumpectomy and breast-conserving surgery, you get neoadjuvant chemotherapy. If it's deemed non-operable, it's too big or location is difficult for approach at its size, you would get neoadjuvant. So we see a lot of neoadjuvant chemotherapy, which is chemotherapy before their surgery. And the neoadjuvant chemotherapy, it generally is anthracycline-containing chemotherapy, although there's new data with pertuzumab, which I'll get to that, followed by a taxane is standard. And you give trastuzumab if HER2 is overexpressed. So still with the locally advanced disease, if the tumor shrinks when they give neoadjuvant chemotherapy, then you can do a mastectomy or lumpectomy. Axillary lymph node dissection is required in locally advanced disease. So that you got to know that. It's It's not required in early stage, or you shouldn't do it in early stage. Radiotherapy is required in locally advanced disease. Everybody gets radiotherapy. So that's how they'll give you little niblets about the patient, and you got to know which ones are what treatment you get. If there is no response to neoadjuvant, the tumor didn't shrink, then you try another chemotherapy, or you can try to shrink the tumor before surgery with radiotherapy as well. So I want to mention quickly the pertuzumab trials. The two trials are, one is the NeoSphere trial, and NeoSphere used docetaxel, trastuzumab, and pertuzumab every 3 weeks times 4 prior, that's neoadjuvantly, prior to surgery. So you see there is no anthracycline in there. Then they received FEC chemotherapy, which is, there's your anthracycline, epirubicin, post-surgery every 3 weeks times 3 cycles. And the PCR, which is a controversial term, but a lot of trials look at PCR. It stands for pathologic complete response. And some investigators hate that term. The use of that term, I think it doesn't mean what some other investigators think it means. But it was higher compared to the other 3 non-pertuzumab arms. So the arm that contained pertuzumab, and it led to FDA approval for neoadjuvant use for pertuzumab, was the NeoSphere trial. I didn't tell you what pertuzumab is, but it's similar to trastuzumab, but it binds at 2 sites instead of 1 site. The Trifina trial, the primary endpoint, it's another pertuzumab trial, was safety and tolerability of pertuzumab during neoadjuvant treatment. All of the regimens compared in the trial had contained pertuzumab. There were 3 regimens, but the highest PCR was revealed in the TCH plus pertuzumab arm. And that's why this treatment is becoming much more commonly used neoadjuvantly. I would say it's probably our most common neoadjuvant treatment now. Pertuzumab is approved for neoadjuvant use and in metastatic breast cancer. NCCN recommends use in adjuvant setting, but the data is really not available. And it's added to our beacon bills because that's how, so locally we use it that way, because the data is maturing. I think it's worthwhile to have one slide about triple-negative breast cancer. Big area of focus of research right now because they're a distinct entity. They are ERPR negative, but HER2 normal. So what do we do with these triple-negative patients? What we are seeing is carboplatin may be beneficial for this disease subtype, added to an anthracycline and taxane-based regimen. Benefit has been demonstrated in neoadjuvant and adjuvant treatment of triple-negative breast cancer. However, breast cancer carboplatin-based regimens are not yet incorporated into national guidelines, but you do see them used locally. Okay? Then we've got, gotta go catch the shuttle. Thanks, lady. Sorry, I'm almost done. Inflammatory breast cancer is a distinct clinical entity. It is rare. It has a poor prognosis. It is often hormone receptor negative and HER2 overexpressed, bad prognosis. Greater than 5% mortality at 5 years, that is really bad mortality rate for breast cancer. We have come very far with the treatment of breast cancer. There is no standard of care. Clinical trials are probably most appropriate for this rare subtype or distinct clinical entity. You should treat it as locally advanced disease, even if it's small. But these patients are never candidates for breast conserving surgery or lumpectomy. They need a mastectomy. And local radiation in this bad cancer is more extensive, and it's very difficult to your radiation burns, curing from the radiation burns when you have this breast cancer is difficult. Sometimes they never heal. Bad cancer. Then the last stage for our last type of breast cancer, stage of invasive ductal carcinoma, is metastatic or recurrent. And the goals at this stage of disease is palliation to prolong life. The median survival at this stage of disease is 3 years, but there are some long-term survivors. And we'd really like to know is what is making those women live longer. And it likely is some immune factor that we don't know yet, or some genetic factor that we haven't identified, which we have identified in lung and melanoma. Other diseases that we have genetic targets, we have that in breast cancer. Bone and soft tissue mets give you a better prognosis and respond better to endocrine therapy. Symptomatic visceral metastases Visceral metastases are metastases to an organ, and generally in breast cancer that is lung or liver. They require chemotherapy. You have to give chemotherapy. But if you've got bone mets, you can probably use endocrine therapy or bone and a bone modulating agent, a zoledronic acid or denosumab. ER/PR positive cancers are more indolent and you respond better to endocrine therapy, even in the metastatic setting. So consider first-line chemotherapy for ER/PR negative tumors and patients with symptomatic visceral mets. The use of combination chemotherapy versus sequential single-agent therapy is widely debated. The test 2 years ago, if you took it then, they would say you always use a single agent, never use a combination. And now we really, for people that have symptomatic visceral organ mets, you should use probably combination chemotherapy. A combination is preferred. There is no standard regimen, and they're made on an individual basis with the provider's preference and the patient's suitability. You can use when you use an initial anthracycline or taxane therapy in the metastatic or recurrent setting, the objective response rate is the complete response and the partial response summed is 40 to 50%. Each time you change chemotherapy for metastatic, because it works for a while, then it doesn't work, you get a shorter duration of response. And high-dose chemotherapy, we learned a hard lesson with that one. Mary and I lived through that. High-dose chemotherapy followed by stem cell transplantation does not improve survival. I doubt they'd ask that question, but it was asked a few years ago. It would be an option to do stem cell transplant in breast cancer, and that is always no. So chemotherapy, I have lists here of chemotherapy that can be used in the metastatic or recurrent setting. The preferred single agents are listed here. And I always have clinical trials on the bottom because they're useful, particularly for recurrent. Chemotherapy, the other active agents are listed here. So you have a lot of things that you can rotate through in metastatic breast cancer, and even if they haven't progressed, but they're really suffering toxicity-wise from a particular agent, they can move to something else. Preferred combinations, if you are going to use a combination for visceral or an organ met, the preferred combinations are here. You might want to go through the mnemonics. I think most of these you have heard in this presentation, but you might want to know what drugs. It's mainly that C, which one's carboplatin and which one's cyclophosphamide. And the E is epirubicin in those combinations. I think it's worthwhile to look at the data so when you're if you are studying, there's the chapters and then there's the slides from the presentation. I think that presenter did a good job on presenting the Bolero 2 trial, and I think that's a recent trial with an interesting recommendation for postmenopausal women. So that use the drug everolimus and exemestane and aromatase inhibitors, both oral agents in metastatic postmenopausal patients. So taxanes, I've got a couple slides on the taxanes in the metastatic and recurrent setting. I've already talked about the first one. Abraxane, though, I think is an interesting drug, but we still use paclitaxel in a lot of our trials as the comparator. When you looked at docetaxel and Abraxane in a 4-arm trial, overall survival was favored when Abraxane 150 milligrams weekly was given compared to docetaxel or other doses of Abraxane. Bevacizumab, I have to have one slide on there because I think it's important historically to know what happened with bevacizumab in breast cancer. There were a couple trials, the Avado trial and the Ribbon 1 trial and the Ribbon 2 trial. Progression-free survival was demonstrated in the Ribbon 2 trial, but overall survival there was no difference, and it was bevacizumab plus second-line treatment. Ribbon 1 was first-line treatment. But the FDA granted approval for bevacizumab for metastatic breast cancer, first line in for HER2 normal patients only, or negative, if you want to call it that, with metastatic breast cancer. The FDA approval was revoked in 2011 because it was determined that it wasn't safe and was not effective, and the FDA directed the manufacturer to conduct more trials. Bevacizumab and paclitaxel is still included as an acceptable regimen, but the decision to use this is complex and controversial, and I think why it remains on the NCCN list is because some of the providers feel that is a beneficial agent in certain types of patients. So a newer agent approved for metastatic breast cancer is Kadcyla, and I think the only thing that could be on the test is where you could immediately eliminate a combination where they had Kadcyla plus trastuzumab. You never give those two together. And the drug on its own has many dose reductions required for toxicity, liver cardiotoxicity, and then once you dose reduce, you do not re-escalate this drug. It's an interesting drug, though. Very interesting. So thank you. I'm surprised I got through in a little bit over an hour. But if anybody is taking the exam, just email me if you want to go through anything that I've covered or any other cancer. I'd love to talk to you about it. Thanks, everybody.